Bismillahirrahmanirrahim. We will start with quote of the day. The bravest heart is the one that stays close to Allah even when it is in pain. I am Dr. Taimia Ayub, and today I will be presenting the topic of vertical programs in Pakistan, global context, and then focusing on National Tuberculosis Program, EPI program, and National AIDS Control Program. I will be giving this presentation under the supervision of Professor Dr. Saira Afzal, Dean Institute of Public Health, Lahore. This is the outline of today's lecture. We will start with the concept evolution of vertical health program, then cover the financing mechanism, vertical versus horizontal versus diagonal approaches. Then we will discuss three main program: National Tuberculosis Program in Pakistan, operational systems of expanded program of immunization, and National AIDS Control Program strategy, service delivery model, and so on. And at the end, we will shortly discuss the role of Common Management Unit and what is this CMU. These are the learning objectives of today's lecture. So let's start with the concept of vertical program. What are the vertical programs? Vertical programs are disease specific or intervention specific public health initiatives that operate with dedicated funding streams, have defined targets and measurable indicators, use specialized workforce and reporting systems, often function semi-independently from general health services. They are commonly used for infectious disease, immunization program, family planning initiative, and disease eradication campaigns. Evolution of vertical programs globally. So the historical driver mainly for the vertical program was the smallpox eradication program and the success of that program during 1960s and 70s. Then expanded program of immunization was started by the WHO in 1974. HIV/AIDS global response has been continued from 1980s onward in different parts of the world, and Global Fund was made in 2002, and Gavi was established in 2000. So these are some of the main drivers and the historical main points for the vertical program. The global trend is that initially the programs are highly vertical, and then gradual they are shifted towards integration and health system strengthening. So, how vertical programs work globally? The core operational functionals of vertical programs are that there is dedicated governance structure. For example, national program managers are there, technical units are established. Then there is earmarked funding, donor plus domestic co-financing, which is such for the EPI case in Pakistan. Then there are standardized guidelines, usually from the WHO protocols, which are to be followed, and parallel monitoring systems are established, particularly to that program. And performance-based evaluation is done, like coverage rates, incidence reduction, and so on. So, delivery mechanism of vertical program are facility-based services, outreach campaigns, community mobilization, or targeted services for high-risk groups. Financing mechanisms, there are multiple financing mechanisms. For example, there can be multilateral funding like from Global Fund, Gavi, World Bank, etc. Bilateral funding from USAID, and then domestic public financing and performance-based disbursement models. So these are financing mechanism, and usually multilateral funding along with the domestic public financing combination is being done. Features include grant cycles, which are about 3 to 5 years, result-based financing, and monitoring tied to disbursement indicators. So there are few clear advantages of vertical program. Rapid scaling up of priority internet intervention is possible. Clear accountability and measurable outcomes can be done. Technical specialization, strong donor confidence, and they are effective for epidemic control and eradication. For example, polio eradication. But at the same time, there are several limitations of the vertical program. They include fragmentation of health services, duplication of human resource and reporting systems, weak integration with primary healthcare, sustainability risk post donor funding. This is the most important issue, even for the donors, that what is the sustainability of a particular program when the funding is going to stop. So we have discussed these approaches yesterday and previously also. So there are vertical versus horizontal versus diagonal approaches. I will just give you the definitions of that. Vertical programs are disease focused. They are standalone structures. Horizontal program are the integrated primary healthcare approach. Then we have diagonal approaches which use disease funding to strengthen overall health system. Sorry. And the modern policy direction is to move ultimately towards the diagonal integration. Vertical programs in Pakistan. Why Pakistan adopted vertical programs? There is a very high communicable disease burden in Pakistan, limited primary healthcare capacity historically, strong donor involvement is being done, need for measurable disease control outcome, and then there are global commitments like SDGs, NTP strategy, and UN AIDS target. Post 18th Amendment devolution to provinces, federal is mainly responsible for technical coordination services. Sorry. So now we come to the first program, which is the National Tuberculosis Control Program or NTP. So National Tuberculosis Program was established in 1990s. Was revitalized with DOTS expansion in early 2000. It is aligned with WHO and TB strategy currently, and it is supported by Global Fund and domestic financing. So the objectives of NTP are early detection of TB cases, universal access to free TB treatment, control of MDR TB, reduce TB mortality and transmission, strengthen TB surveillance and notification. Governance structure is that there is a federal TB control cell, then provinces have their own provincial TB control programs, then there are district TB coordinators which collaborate with teaching hospital and private sectors, and technical working groups like MDR TB, and there are labs and so on. So the working mechanism of NTP is that there is first case detection, passive case finding, which is facility based, and then active case finding from context and high risk groups. Diagnosis is by sputomicroscopy, gene expert, MTB or RIF, culture and drug susceptibility testing. Then in treatment, we have DOT strategy, standardized drug regimens, and patient adherence support. MDR-TB management is is in particularly specialized centers and second line and through second line drugs. Monitoring and evaluation by TB MIS, cohort analysis, and treatment success rate monitoring. Financing of and partnership of NTP are government allocation, global fund grants, WHO is providing the technical assistance, and public-private mix a model for notification and treatment. So NTP has a few achievements, and there also have been several challenges in the process. The achievements include nationwide DOTS coverage, expansion of gene expert network, and improved notification rate. Whereas challenges include underreporting from private sector, MDR-TB burden, stigma, and sustainability of funding. So this is the screenshot which has been taken from the website of the National TB Control Program. And the latest website is up till 2022. And currently, the TB Control Program, National TB Control Program, is under the CMU, and I will give a brief explanation of CMU at the end of the presentation. So, TB Control Program is currently under the Common Management Unit, and it is working under that. So, it's there. And also there has been establishment of a DHIS2 and TB technical support system center, and they are also providing toll-free number, and you can contact them on this helpline to get different information. This was also taken from the Common Management Unit website. Now we come to expanded program on immunization. The expanded program of immunization or EPI was launched nationally in 1978. It initially covered 6 antigen, which was expanded to include additional vaccine over time. It is currently being supported by WHO, UNICEF, and Gavi. There has been progress of EPI in Pakistan. It was launched as explained in 1978 to protect children by immunizing them against childhood tuberculosis, poliomyelitis, diphtheria, pertussis, tetanus, and measles. Later, with the support of development partner, a number of new vaccines, for example, hepatitis B, Haemophilus influenza type B, and pneumococcal vaccine were introduced in 2002, 2009, and 2012, respectively. An inactivated polio vaccine in 2015. Then later on, rotavirus was introduced in 2017, typhoid conjugated vaccine TCV in 2019 in Sindh, Islamabad, Punjab, and later on in Islamabad. Measles vaccine is now being replaced by measles rubella, which also protects against rubella and congenital rubella syndrome. Also, the vaccine for HPV is also being included for the older girls in the EPI program. Each year, the EPI program targets nearly 7.5 million children across the country and close to 5.5 million pregnant women against tetanus, with the goal of averting childhood mortality in Pakistan. So, this is a timeline of EPI program. And you can see it was a pilot project in 1976. Then it was expanded nationwide in 1978. Activities were intensified in 1980s, and in 1990s the national polio immunization days were started. And you can see how different vaccines were included over the time in the API program. So, the objectives of the EPI program are to reduce morbidity and mortality from vaccine preventable diseases, achieve high routine immunization coverage of greater than 90%, maintain cold chain integrity, conduct surveillance of vaccine preventable diseases. This is the current schedule of EPI program in Pakistan. It starts with birth and then it continues up till 15 months of age. And there are different types of vaccine and to protect children over the course of their childhood. The organizational structure of EPI program is that it has federal EPI cell, then there are provincial EPI manager, district EPI officer, vaccinators and LHWs coordination, and then there are cold chain technicians. So this is the organizational structure. Operational mechanisms are that routine immunization is through fixed and outreach sessions, cold chain system maintenance through cold boxes, temperature loggers, etc., vaccine logistic management, supplemental immunization activities, surveillance system through AFP for polio, measles surveillance, and AEFI reporting. Financing and supply chain is maintained by government funding, Gavi co-financing model, UNICEF procurement support, and Logistic Management Information System or LMIS. Similar to any program, EPI program has different achievements and there were also few challenges. Achievements include introduction of new vaccine, for example, pentavalent and pneumococcal vaccine and HPV vaccine over the course of time. There has been reduction in vaccine preventable diseases in Pakistan. Challenges include coverage inequities, vaccine hesitancy, cold chain gaps in the remote areas, and data quality issues. So this is the character which I am sure most of you have seen across in different hospitals. It is about Tiku, and it is saying that our Tiku protects our children, and we can protect together, and vaccines do work. So now we come to AIDS control program, National AIDS Control Program or NACP. NACP was established in 1986 to 1987, initially focused on hospital-based diagnosis of HIV cases, gradually shifted from clinical model to a community-focused prevention approach. Emphasis moved towards surveillance, prevention, and outreach among high-risk groups. Government of Pakistan has a sustained national response to HIV, which is implemented through collaboration between National AIDS Control Program, provincial and AJK AIDS Control Program, UN agencies, bilateral and multilateral donor, NGOs and CSOs, people living with HIV representative organizations. It operates at national, provincial, and grassroots levels. Strategic approach for the AIDS control program since 2015 has to be under the enhanced HIV control program. Pakistan adopted an investment approach. Programming is designed according to Pakistan concentrated epidemic pattern and focus on targeted intervention for key population rather than general population or mass programming. So this is the service delivery mechanism. HIV treatment services is delivered through governmental arts centers, prevention and support services, excluding treatment, providing mainly through global fund support, public-private partnership between governments and NGOs and CSOs, and NACP currently working alongside with the National Institute of Health as a parallel program structure. So the funding is mainly through global fund support and public-private partnerships. The core mandate of the HIV National AIDS Control Program is to prevent new HIV infections, expand HIV testing and counseling, provide free antiretroviral therapy, ensure safe blood transfusion practices, and strengthen surveillance, and mainly to reduce stigma around HIV disease and AIDS. Service packages, targeted prevention for key population like people with disabilities, sex workers, males having sex with males, transgender people, voluntary counseling and testing, art service delivery through art centers, and prevention of mother to child transmission component where functional and strategic information and surveillance to be provided. So then we have provincial implementation of the program in Punjab, particularly, which is the largest province by population. 55% of the national population is in Punjab, and provincially managed response under the Punjab AIDS Control Program. Punjab AIDS Control Program has several responsibilities and services, which include free HIV testing, counseling, and art through art centers across the province, targeted outreach for most at-risk population, stigma reduction campaign, capacity building for clinicians, and lab support. Then program financing has included PC1 project funding cycles. For example, PACP PC1 approved for multi-year period with donor and provincial component. Implementation and absorption of fund has at times been a challenge. So there are some operational strengths for Punjab AIDS control program in relatively larger art network, stronger provincial DGHS coordination mechanism, and active external partnership, UN agencies and NGOs. Some of the key gaps have been suboptimal budget absorption in some project cycles, need for improved case finding among women and children, continued stigma and service access barrier for key population. Similarly, Sindh, Khyber Pakhtunkhwa, and Balochistan have their own AIDS control program. And in Sindh, for example, large urban epidemic has been observed in Karachi. Multiple NGO UN partnerships are in the provincial AIDS control program is active in outreach and art scale up, and provincial strategies and operational plans are being available through health department portal. Khyber Pakhtunkhwa similarly has its own provincial AIDS strategy from 2021 to 2025 that aligns with national targets but emphasizes local context, for example, service access in remote districts and conflict affected areas. Then Balochistan had also its age strategy from 2021 to 2025. Challenges include geography, low service coverage, and human resources. Now we come to another important component of the presentation, which is the Common Management Unit or CMU. So what is CMU? It is a federal coordination body under the Ministry of National Health Services, which was established to centrally manage major vertical disease control program in Pakistan. Why was it created? To reduce fragmentation among vertical program, to improve financial management and donor coordination, to centralize procurement and monitoring systems. These three programs are currently in under the CMU, National TB Control Program, National AIDS Control Program, and Malaria Technical Unit. The key functions of CMU is the national strategic planning, donor coordination, especially with Global Fund, centralized procurement of medicines and diagnostics, financial oversight and grant management, and finally monitoring and evaluation of all the activities. Role of CMU after devolution of 18th Amendment: provinces implement program, whereas CMU ensures national coordination, procurement, and reporting. Importance of CMU is that it ensures uniform standards across provinces, it strengthens vertical program and governance, improves efficiency and accountability. So now we come to multiple choice questions part of the presentation. So MCQ number 1, which features more strongly differentiate a vertical program from a horizontal primary healthcare approach? Community participation, integration into district health system, disease-specific earmarked funding and parallel reporting, use of WHO guidelines, and focus on preventive care.
C.
Yes, the answer is C, disease-specific earmarked funding and parallel reporting. A province received global fund support for TB and establishes a separate monitoring system outside the routine DHIS. What operational characteristics does this reflect? Diagonal strengthening, health system integration, decentralized government, parallel monitoring structure, or community empowerment?
D.
Yes, it is D, parallel monitoring structure. Pakistan's HIV epidemic is classified as concentrated primarily because HIV prevalence exceeds 1% in general population, HIV prevalence exceeds 5% in defined key populations, ART coverage exceeds 90%, rural transmission predominates, or blood transfusion is main driver.
B.
Yes, the answer is B. HIV prevalence exceeds 5% in defined key populations. Which financing feature is typical of global fund supported vertical programs? Result based disbursement, open ended funding cycles, block grants without indicator, exclusive domestic financing, or private insurance reimbursement?
A.
Yes, it is A, result based disbursement. An art center reports frequent stockouts due to delayed federal procurement despite adequate provincial demand forecasting. This most directly reflects weakness in surveillance system, case detection strategy, service integration, outreach to key population, or centralized supply chain coordination.
E.
Uh, it is centralized supply chain coordination, issues in centralized supply chain coordination, because there have been reports of frequent stockouts. After the 18th constitutional amendment in Pakistan, which function remains primarily at the federal level under CMU, routine immunization sessions, district level outreach activities, community mobilization, health facility staffing, national donor coordination, and procurement.
E.
Yes, it is E, national donor coordination. Which operational element of EPI most directly ensures vaccine potency at service delivery points? AFP surveillance, cold chain maintenance system, supplement immunization activities, evaluation surveys, or social mobilization?
B. B.
Yes, it is B, cold chain maintenance system. In a major city, HIV prevalence among people with disabilities exceeds, people with special needs exceeds 5%, while general population prevalence remains below 0.1%. What is the most appropriate strategic response? Mass nationwide screening of entire population, universal travel restrictions, closure of art centers, targeted intervention for key population, or school-based vaccination program?
D.
Yes, it is D, targeted intervention for key population. A policymaker proposes integrating HIV, TB, and maternal health screening into one PHC package while retaining disease-specific funding. This approach best represents pure vertical model, pure horizontal model, diagonal approach, privatization model, or decentralized financing model.
C.
Yes, it is C, the diagonal approach. This is the answer key of the MCQs. This is the YouTube channel where this video will be uploaded, of Institute of Public Health official channel. And thank you very much for listening.
Thank you.